and Dr. Carl Christensen. Dr. Weiner is the Section Chief of Addiction Medicine and the Medical Director of Substance Use Disorders at St. Joe's in Ann Arbor. He is also the Medical Director of IHA Pain Management Consultants. He is the chair of the Planning Committee of the American Society of Addiction Medicine course, Pain and Addiction, Common Threads, and is a member of the Planning Committee for the American Society of Addiction Medicine annual meeting. He is the editor of the ASAM Pain and Addiction Handbook. Dr. Weiner is also the chair of the Board of Trustees of non-pharm. Dr. Christensen is a clinical associate professor at the Wayne State University School of Medicine and has a private medical practice in Ann Arbor, Michigan. He is the medical director of the James Wardell Women's Recovery Center, the medical director of the Tulane Medical Research Clinic and of the Department of Psychiatry at WSU, and the medical director for Don Farm. He is the past president of the Michigan Society of Addiction Medicine and the current medical director of the Michigan Health Professional Recovery Program. He is a member of the Advisory Board of Families Against Narcotics in Wayne County, and Dr. Christensen has received numerous teaching awards and has been named one of the top docs in addiction medicine in Our Magazine 2006. Please join me in welcoming Dr. Mark Weiner and Dr. Carl Christensen.
So I'm Carl Christensen, I'm the old guy, and I'll be leading off. And my part is talking about the different regulatory effects or the different attempted regulations and trying to control the opioid epidemic and the prescribing epidemic. So I'll talk about who is at fault and the solutions from the Board of Medicine, the Impaired Doctors Monitoring Program in Michigan, and also our friends the DEA, and then the other answer to the prescribing epidemic from the CDC, and I'm going to sit down because I'm the old guy. And also we'll talk about something that just came out about 1 week ago, which are the new Michigan opioid laws, and we'll talk about how that affects you and how all of this affects you. And we'll also, if we have time, we'll talk about why try and get off opioids. So the first thing is, who is behind the opioid epidemic? And it is easy to blame Big Pharma for this. This is a graph we'll see a couple times, and this is opioid sales, opioid deaths, and patients admitted to opioid treatment. And they are exactly the same line. So you can say that dying from opioids and being treated for opioid addiction is directly due to the push to sell opioids in the US. And there is a lot of pushback from pharma. When the CDC guidelines came out, the makers of OxyContin bankrolled an organization of pain doctors into suing the government, and it came out that they were the organization was actually funded by pharma, and it kind of blew up in everybody's faces. But except for the pills that fell off a truck and the ones who came through the internet, every prescription narcotic that you get your hands on came from someone's prescription. So the real, or a major part of the problem is the prescriber. And this is one of the first doctors who was intervened on in the state of Michigan. His name has been hidden, even though he's been convicted. This was a doctor up in Hamtramck that came to the attention of the police and the authorities because there was actually a line around the block in the morning to get into his family practice clinic. And fights were breaking out all the time. And I've been practicing medicine for over 30 years, and I've never had a line out to the door of my office, much less around the block. So there was something going on. And when it was finally investigated, and it was actually Blue Cross that did a lot of the investigation, and I was part of that, and we found out that he was not the #1 prescriber of opioids in Michigan. He was only #2 behind a place called the University of Michigan Hospital. So which meant he was the head of the DMC, St. John's, St. Joe's, and everybody else. So he no longer practices. Oop. And Michigan is in the Big Ten, meaning that we are in the top 10 states in the country in terms of prescriptions per person. There are 101 narcotic prescriptions written for every 100 people in Michigan. So everybody in here has received a script for Norco in the past year, right? Okay, that tells you somebody else is getting a lot more than you are, okay? And there's a lot of evidence saying that doctors overprescribe. And we have to ask ourselves why. Why would someone risk this? And there has always been this list of causes called the 4 Ds. Doctors are either dated, meaning they are behind the times. They're dishonest, which is the crooked doctor. Duped, which means the people pleaser. Or disabled, which means the addicted doctor. And these 4 have been around for quite some time. And when you talk about dishonest doctors, this is a pain clinic in Florida that is obviously nothing more than a criminal enterprise. They offer massage and OxyContin in the same office, okay? And these are shut down by the DEA frequently and only to spring up in another location. But even though these are a huge problem, they're only a fraction of the prescriptions that are going on. Or you can say that doctors are dated. You have to have 50 hours a year of continuing medical education to keep your license in Michigan, and a lot of docs don't know how big the problem is. I was giving this talk way up north a couple of years ago, and a doc came up to me afterwards and asked me what a benzodiazepine was. And he was in his 40s, okay? And he had been prescribing them. He really wasn't sure what they were. Or you can say that doctors are addicted. 15% of the population has the disease of addiction. You hear about this all year long in this series. Doctors are overrepresented in that group, and nurses are even further overrepresented. So somewhere between 15 and 25% of people that prescribe narcotics have a future, a past, or a present history of addiction. And here is the biggest one of all. Doctors are people pleasers. One reason I went to medical school was so that people would like me, okay? There is nobody happier than someone leaving my office with a script for Norco, Soma, and Xanax. And there is no one more disgruntled than someone leaving my office with a prescription for nothing. And you quickly learn how to please your patients, and once your patients figure out that you want them to be happy, they call their friends, and they call their friends, and so on, and so on. And this is one doc down in Florida who got in trouble with the authorities for just writing everything in sight, and her defense was that she had been duped by her patients. And doctors have been under a lot of pressure. This was something that was launched back by the Joint Commission of Hospital Accreditation and the American Pain Society about 10 years ago, and we are supposed to ask a patient every time what their pain score was. If their pain score is over 4, we are supposed to turn the medications up. And we've known for a long time that this is a bad idea, but still, most of us, when we round in the hospital, if we see John Doe and we come in and he's on the phone, watching TV, eating a sandwich, and they say their pain score is 10 out of 10, they want their pain pump turned up and we don't do it, we may have a complaint lodged against us by one of the employees of the hospital. It's a major, major problem. The Joint Commission has now denied publishing this, but even though they may have stopped, they never told anybody. So this has been going self-perpetuating, and it still is a part of Medicare payments in the US. Now, this is my contribution to medicine. This is the 5th D, defamation. And this is brought on by social media. If you come to see a doc today and you don't like how you were treated, you can jump on your smartphone, and by the time you get home, you can launch an attack against their professional reputation. And this goes on and on and on. And you can bet that this is something that is taken very seriously by the prescriber and also by their employer, the hospital or the medical group or whoever it is. And here's some examples of stuff you can see on the internet. Don't waste your time. 1 score out of 5. Wait time, 60 minutes. Highly dissatisfied, 37%. Worst doctor I've ever seen. Okay? These are the kind of things that if you read them and you are a provider, you become very scared. Okay? Now you can guess who this is. This is me. Okay? And this is my favorite evaluation of all time. He's a complete asshole. He's a controlling son of a bitch who bases his decisions without completely listening to you. So the president has nothing on me, all right? And in my profession, my employers expect that I will have disgruntled customers. But if I was a new internist or primary care provider and I wanted to build my reputation with the hospital and I read this stuff, this can end your career. And it still happens to people. It's a major, major problem. And eventually, if things go on long enough, the DEA gets involved Here's one Michigan doctor who got sentenced to, I think it was 7 years for prescribing prescription drugs, and he had been caught several times already, and I don't think he has gotten his license back. But if the DEA hears about someone and they hear enough, then they launch an investigation, and they are very, very, very tenacious. So let me give you an example. This is a doctor out in LA who knew that people were watching, so this doctor required you to bring in an x-ray showing why you were in pain. And a patient came in and showed them the x-ray, and if you look at this, this is actually somebody who is in pain. There is hip dysplasia on the right side. This is probably a pretty painful condition. However, there is also an extremely long coccyx, what most of us would call a tail. This is an x-ray of a dog. So the patient, who was actually an undercover narcotics agent, showed the x-ray to the doctor, and the doctor said, "What do you want?" And what the agent wanted was a prescription for OxyContin and the doctor's license, and he got both. So this is a doc out in LA, and he himself is no longer practicing medicine. So the other side of the coin is that if you are impaired, addicted to drugs or alcohol, or have a mental health diagnosis, and you are a doc, a nurse, or a pharmacist, there's an organization that will support you and keep it confidential and get you treatment and monitor you for 3 years, 5 years in most parts of the country. And it's called the Michigan Health Professional Recovery Program. And I'm the current medical director. This is not for crooks. This is for people who are addicted and make bad decisions while they're addicted. There's also the Board of Medicine. I'm going to put a phone number up in a few minutes. If you call the Board of Medicine and say that Dr. Christensen is practicing a terrible job, he's writing too many prescriptions, my kids all have narcotics from him, you can call them. And you can also go on a website. If you look up Laura and Board of Medicine, you'll find this website. And here is a physician, and here is his string of suspensions between 1997 and 2016. And he now got this one dissolved, and he is back at work. And this just goes on and on every few years. So if you see one of us practicing illegally, either writing too many prescriptions or selling prescriptions or selling pills, this is a phone number. It's in your handout. It's the complaint hotline for licensing and regulatory affairs. If you see one of us taking pills in the parking lot, however, that means we have a drug or alcohol problem, and you can call this number, HPRP, and there will be someone who will interview you, take your information. They will ask you your identity, but it will be kept confidential, and an investigation will be launched on whoever that doctor, nurse, or pharmacist is. Now, next is the CDC. The CDC got involved over the past couple of years, and they published guidelines about 1.5 years ago, and they are a major source of controversy. And they are going to wind up affecting everybody here in the audience or a family member of yours. And these guidelines are now being used to dictate amounts of medication, what types of medication, and how long you can take it for. So this is what affects you most directly. It's also one of the most boring presentations you're ever going to hear. So the most difficult part of prescribing pain medication is starting and stopping. That's when most deaths occur or most problems occur, when you're tapering somebody off. So taking off is the same thing as getting somebody started on pain medication, and then landing is the same as getting somebody off pain medication. And both parts of that are fraught with problems. In the middle, where you're simply prescribing the medication, things often go very smoothly. So here are the CDC guidelines. And I want you to note one thing. We talk about 4 grades of evidence. 2 good grades, 2 bad grades. Level 3 and 4 are junk. Every recommendation made by the CDC was based on level 3 or level 4, junk. And I'll talk about why they justified that in a couple minutes. And there are 3 sections: when to start, when to continue, which one to pick, when to decide to stop them, and once you started, assessing the risk, okay, which is kind of backwards, but that's the way they did it. I'm going to go through these very quickly. I'm not going to read the guideline. If you want, it's in your handout, or you can just Google CDC guidelines, and you can download the entire thing. But I'm going to give you a one-sentence blurb for most of these guidelines so you realize what you're up against. Guideline 1 says don't use opioids first, okay? And basically what this says is that opioids have not been proven to be better than either non-narcotic medications or no medication at all. And if you are going to use narcotics for pain, you need to combine it with other non-narcotic choices. And there's things like acupuncture, physical therapy, chiropractic, massage therapy, counseling, pain psychology. There are medications that are anti-epileptic drugs that are specialized in treating nerve pain. And there are these are old antidepressants that don't work for depression very well, but they work good at treating chronic pain. And they also help you sleep, which is probably part of the way they work. But these are all non-narcotic. They are not harmless. This and this can result in death, okay? And this is usually not covered by your insurance company. So there's problems for every solution that we're going to talk about tonight. Guideline 2, you need to discuss the risks and benefits of opioids with the patient. And this sounds kind of obvious, but a lot of times what we used to do back in the dark ages was if somebody came in the office and complained of back pain and there wasn't anything obvious as far as addiction, we just start prescribing Vicodin, which we now call Norco. And we now know that that may result in somebody never getting off the Vicodin. So you should talk about the risks and benefits and how you are going to stop the medication if it turns out there's more risk than benefit. And if you look at this, there are all kinds of downsides. Disability, loss of family, addiction, dependence, overdose. As you know, opioids are now the major cause of death in the U.S. under age 50. It's overtaken everything else, and it's on the way up. We're talking about 60,000 deaths this year. So there's a lot of downside compared to the effectiveness of these drugs. And guideline 3 is essentially the same thing. During opioid therapy, sit down and talk about how it's working and talk about what the provider's responsibilities are and the patient's responsibilities are. And this is the same slide. If you talk about the risks and benefits, as opioid use goes up, so do deaths. And you need to emphasize to patients, and I talk to patients about this all the time, and I say, here is a graph that shows what your risk of overdose is on the medications you are. And they are just stunned. They've never heard it before. All they've heard about is people dying from heroin overdoses, but they've never heard about people dying from Norco or oxycodone overdoses, which is actually the more common kind of death. And again, there is one special dangerous pill out there, and that is methadone. Methadone is used for two different things in the U.S. It's used to treat addiction, and it's used to treat pain. If it's treating addiction, you have to go to a methadone clinic, which is run by the government and the DEA. You have to stand behind this bulletproof glass, get your little cup of methadone and drink it in front of the nurse. And there's a lot of non-recovery type activity going on in the methadone clinic, and I know this because I work at one. And it is usually not a real recovery-oriented environment. But it's relatively safe because someone sees you every day. And we see when you're getting in trouble, when you show up too sedated. This is methadone pills. This shows here that methadone pills are directly related to methadone overdose and methadone prescriptions. Methadone accounts for 3% of the prescriptions and 30% of the deaths in the U.S. We can make a huge dent just by not using methadone pills or only people who were experienced in using methadone prescribing it. Guideline 4, when starting off, use short-acting opioids and don't use long-acting opioids. Dr. Weiner will confirm that when he and I were both in training, when he was in his youth, when I was in my youth, he still is in his youth, that we always were taught that you should use long-acting opioids. They were safer, they were better, and they controlled pain better. It turns out there's no evidence for that. And there's evidence that they're more dangerous. Because why? The prescription would say take twice a day, every day, don't stop, never stop taking the medication. So you can have somebody who's getting in trouble, getting close to an overdose, who does not stop because the bottle says don't stop. Okay? Short-acting opioids are called PRN, which means as needed, which means that if you feel kind of goofy or woozy and you don't want to feel that way, then you'll back off on the medication. So always start with short-acting opioids and never start with OxyContin. We used to prescribe OxyContin after C-sections. We give somebody a bottle of OxyContin and say, here, take this home, and you'll feel fine. And we were right, but that wasn't the effect we were looking for. Okay, Guideline 5. Opioid deaths are related to dose. And there's a number that you're going to hear. It's called MED, which stands for morphine equivalent dose. Morphine is like the gold bullion that we compare gems to and paper money to and everything else. And the government has cutoffs that are somewhere between 50 and 100 milligrams of morphine where you start worrying about increased chance of dying. And this is chance of overdose death, the relative risk. So this person has a 4 times chance of this person, and this goes below 20, below 50, below 100, and over 100, and there is a 9-fold increased chance of dying when you're taking over 100 milligrams of morphine. And there are a lot of patients who are on that dose or higher. And a lot of that is due to long-acting opioids. They used to make a 100 milligram dose of OxyContin. I don't think they do anymore. But right off the bat, you were taking 240 milligrams of morphine a day without taking anything else. What about somebody who is not addicted, who's never been on pain meds before, and has had surgery and gets a prescription for pain meds? Are they in danger? We used to think, no. Unless you have a genetic predisposition, you're okay. Nothing's going to happen. And now it's been shown that a significant number of people who start opioids after surgery never get off them. And a lot of this work was done by Dr. Chad Brummett at the University of Michigan, and he's done an amazing amount of work in this field. So you often begin with long-term opioid use, starts with acute use, and when you start giving opioids for acute pain, you should give no more than the amount needed, and 3 days or less will often be sufficient. 7 days will rarely be needed. Now, there's some exceptions to this, okay? This gentleman here is probably going to be in the hospital longer than a week, okay? And this gentleman's going to be kept on opioids. But when you hear this, you think, that sounds strange to say I can only have 3 days of pain pills. How many people in here, when they had a dental procedure done, got a full prescription of pain meds? Okay? It's pretty common. So what they found was if you take a prescription for only 1 week, which is very common, there's a 5 to 10% chance that you won't be able to stop. Now, whether that's because you got addiction or whether it's because you became physically dependent, we don't know. But we know that a lot of people don't come off this stuff, even with a week. If you're on a prescription for a month, it's 15 to 25%. And also, this is very, very surprising. It doesn't matter what kind of surgery you had. If you had a D&C, which takes 5 minutes, or a hysterectomy, which takes weeks to recover from, the chance of getting hooked on opioids is the same. And what really counts is what other problems do you have? Do you have anxiety, depression, addiction? Do you smoke? Okay, that's what predicts whether or not you're going to get onto pain meds and not be able to get off. And 6% total never get off pain meds after surgery. Now, 6% doesn't sound like much, right? 1 out of 20. But think there's over 1 million surgical procedures in the U.S. a year. Well, wait till the end, okay? Yep. All right. Guideline 7, if the pain pills don't work, don't keep prescribing. So you're supposed to, if you start somebody on pain meds, you're supposed to have them come right back, see how they're doing, and make adjustments. And if they're not working, don't bump up the dose, okay? And then after that, you should keep seeing them at the maximum every 3 months, and actually the DEA pretty much insists on the 3-month rule, and shorter if the patient is at higher risk. And if it's not working, don't keep going. If you had a doc who was giving you a blood pressure medication and your blood pressure wasn't going down and all the doc did was kept writing for the same medication over and over again, you realize that you had an idiot, right? But in this situation, when someone starts on pain medications and they're not working, they don't want to come off them because opioids do something to your brain and you don't want to give them up, even if you don't have what we call addiction. And there are solutions to this. Here is a gentleman who is intubated. He is an OxyContin addict, and he is being flooded with an opioid blocker, naltrexone or naloxone, and he is going through incredibly severe withdrawal while he is unconscious. And then he wakes up and they tell him that he is cured. And I have one colleague who went through this. He was a veterinarian who got addicted to opiates, and he did this, and he said he woke up being carried across the lobby of a Holiday Inn in a diaper. And they put him in a room, and for a week he sat in the room with a diaper, and then as soon as they let him out of the room, he went back out and bought more opiates. So it's not, there's really very little evidence that this kind of treatment is successful. Another thing is, and we'll talk about it at the end tonight if we have time, if somebody is on more than, say, 50 milligrams of morphine, which sounds like a lot, but that's 5 Norco a day or 3 Percocet a day, you should also offer a prescription for Narcan. And Narcan is the opioid reversal, and even if somebody is severely affected and they stop breathing, this can bring them back. The exception is if somebody has been using heroin and gets a dose of fentanyl or a fentanyl analog, that sometimes it is not reversible. And they talk about dose, and you should also offer it to somebody who has a history of higher opioid dose, somebody who's already overdosed, a history of addiction, should be offered Narcan. I would recommend to you that this person should not be on pain medications in the first place. This is a disaster waiting to happen if somebody has this history. Next number is do a MAPS. MAPS stands for Michigan Automated Prescription System. When I started doing this in 2005, it took 3 days to get a report back, which meant that you were long gone from the office, right? But now it is virtually real time. You can just type in someone's name, their birth date, and about 10, 15 seconds later, you get all the controlled substances for the past 2 years. So you know if someone's been doctor shopping, or you know if someone's also getting sedatives or stimulants or muscle relaxants. And you should do it before you start, and then you should do it when a patient comes back for another controlled prescription. And you should not be afraid to do these and not be afraid to share them with the patient. This is information that can save someone's life if they are doctor shopping and mixing dangerous drugs. Here is somebody who came into my office and wanted treatment for addiction and was not getting any controlled substances, okay? And they had a little heroin problem they hadn't used for a while. They just wanted a little treatment and they'd be okay. And they didn't want to answer any questions about their medical history. And here's their prescription search: Norco, Norco, Valium, Valium, Norco, Valium, Norco, Norco, Valium, Valium. And I said, you know, can you help me to understand what's going on here? And his response was, well, I'm not taking them. He was selling them, okay? So this is drug diversion, this is drug sales, this is a drug dealer. And he was offered the chance to stop getting the prescriptions, but has so far declined. Number 10, this is very controversial, but you should get a urine drug screen before you start treating anybody for pain medications, and with pain medications. And drug screens are fraught with mistakes. You have to use the right drug screen, you have to look for the right drug, and you have to interpret it properly. And if you interpret it the wrong way, you can cause a patient more harm. But if you don't test their urine, you can find somebody who is really abusing medication and is at risk for an overdose. So here is somebody who came in to see me, and they were getting a prescription for Norco. There is no Norco in here. There is heroin. I'm sorry, there is some Norco here. There is heroin, fentanyl, codeine, and marijuana. And what they were doing was they were trading our Norco for heroin. Okay? So this is full-blown addiction. You are not doing this patient any benefit at any time by giving them more Norco. Here's somebody who was prescribed buprenorphine, which everyone calls Suboxone, and there is some Suboxone in here, but there's also this drug here, which is a fancy name for heroin, okay? And they were mixing heroin and Suboxone, which probably meant what they were doing was taking Suboxone during the week and working and then using heroin on the weekend. A very dangerous thing to do. Again, there is no legitimate reason for this to be going on. So, Guideline 11, you should avoid prescribing opioids and benzos together. Why? Because if you take, let's say you take Norco and oxycodone together, they actually fight for the same spots in your brain. And that actually, if you're taking a drug like methadone or Suboxone for addiction, that helps protect your brain. But if you take Norco and Xanax, or Norco, Xanax, and Soma, which is called the Holy Trinity, it all goes to different spots in your brain, but it all has the same overall effect. It makes you stop breathing. And that's how people die from narcotics. They stop breathing. So the combination of an opioid, like hydrocodone, and Xanax is not only kosher, not kosher with the CDC, there is an FDA warning against it. It now has a black box warning, which means that's the strongest recommendation that the FDA can make against a combination of drugs. And this came out, I think, just a few months after the CDC guidelines. And they say the same thing. You should not mix opioids with benzos, sleeping pills, or muscle relaxers. Now, it turns out that if you are taking a opioid alone, Norco alone, this curve down here is your chance of dying from an overdose. And it goes from 0 to 50 milligrams to 100 milligrams to 200 milligrams. So it's going up as you increase your concentration or your amount of Norco. What if you're mixing it with Xanax? Look what happens. Your chance of dying triples when you mix Xanax. What if you stop taking Xanax? Here's the weird one. You still have an increased chance of dying. No one knows why. The people who used to mix Xanax and Norco and stopped are now still at increased risk of dying. And there's probably an explanation, like they're still taking Xanax. But this is something that shows that it really is not a safe combination. And not only Xanax, but Klonopin, Valium, Ambien, and Soma. Okay? Soma is a muscle relaxer, which the older citizens in the room may have known as Miltown, if you go back to the 70s and the 60s. And in your body, Miltown is converted to Soma, and it is a muscle relaxer that works for someone who's had a muscle injury for about 3 days. There is also something called a Soma coma, where you buy a bottle of Soma off the street, you buy a 6-pack of beer, you mix them, and you come to a day or two later. And it's very, very prized. It's a very popular drug. Okay, so dangerous combinations. The Holy Trinity is the most famous one. And that is a combination of a short-acting opioid like Norco or Percocet, and a muscle relaxer, which is usually Soma, and a benzodiazepine, which is usually Xanax, so it can be another one. And you may have heard of Scissorp. There's a famous musician who likes this combination. This is Phenergan cough syrup with codeine mixed with some kind of pop, fruit-flavored cola. And there's a diagnostic sign in the emergency department when someone comes in the ER and they are obtunded or overdosed and their mouth is purple. That's from Scissorp. You've all done that, right? Okay. All right, Guideline 12. If someone is diagnosed with addiction, you should offer what we call evidence-based treatment for opioid addiction. Now there's a talk next month, which is even more boring than this, about does medication treatment work in addiction, but we're not going to have time to go into it tonight. But basically, medication-assisted treatment for opioids includes buprenorphine, which is known as either Zubsolv, Suboxone, Subutex, It can be 12-step treatments. It can be Vivitrol, which is an injection of naltrexone, that's an opioid blocker, or it can be methadone. And these three are accepted by the government, and this one works too. But you need to refer someone to treatment if you've diagnosed them with addiction. If you just send them out from your office, which is what happens very often, you're risking an overdose. Okay, so at this point, I'd like to take a break and introduce Dr. Weiner.
Hi, everyone. I'm Mark Weiner, Dr. Christensen's sidekick, and I guess I'm providing the sedation for tonight's festivities. So, if you're in recovery or you know someone in recovery, you should be right now very afraid to have pain after Dr. Christensen's discussion. And if you're not afraid already, I'm just going to throw in that not only do doctors know very little, or what they know is very dangerous regarding treating pain, they know nothing about treating addiction in general. It is not part of most medical school training. It is getting in just a little bit, but it is really not present, and most doctors practicing know virtually nothing regarding addiction. So if you do have substance use disorder, if you do have addiction, if you're in recovery, if you know someone in recovery, this should make you very concerned and very afraid. So my part of today's talk is to talk about those fears and concerns and try to address them to some degree so you're only slightly less afraid. So again, we're going to talk about fears and concerns. I take care of patients who have addiction. I take care of patients who have addiction and pain. And I can tell you a lot of the fears and concerns are very common. Sometimes they're vocalized, sometimes they're not. It'll make sense when we go through the list. But I'll tell you, it's not only the person who has the condition, but it's often the family member, the caregiver, the spouse, the mother or father, or son or daughter who's in the room, who's very frightened about what's going to happen. And their fears are pretty much universal throughout. We're going to touch briefly on myths about managing pain, because after this discussion, you might think certain things, and we want to dispel those myths. And myths about treating people who have pain, who have addiction. And suggestions briefly about how, if you find yourself or a loved one in this situation, how you might improve the outcome. Primarily that means avoiding a relapse based on the treatment. So if you're the person who has addiction, if you're in recovery and you have a painful condition and you go to the doctor's office, I can tell you if you have one of these thoughts or fears, you are not alone. These are common things. Very common is the thought, I'm afraid the doctor is going to give me something, so I'll relapse. Because people understand a lot of doctors do not get addiction. Of course, on the other hand, you could be someone who says, I hope the doctor gives me something so I can relapse. It will be a freebie. It'll be a free lapse. It'll be his fault. It won't be mine. Patients can feel the sense that they're going to be abandoned and think, you know what, I don't know what they're going to say, but my expectation is I'm going to be left to suffer in pain because that's what doctors do to addicts. And there might be some truth to that. With lack of training, that sometimes is the outcome. Some people feel badly because self-esteem is often a target in addiction and say, I should suffer, and I should suffer. I deserve to suffer. I should be in pain. And then on the other hand, since I'm going to be in pain, I might as well just relapse because, it might as well. It'll help me. There's nothing the doctor should do for my pain because I'm an alcoholic or drug addict. Again, kind of a low self-esteem statement. If you have this thought, it's kind of scary. I should be safe because I like my doctor and he or she would never prescribe something that would hurt me or my sobriety. Again, without training, well-meaning physicians will prescribe things that you can. There are studies that chances are greater than 50%, even if you disclose that you have addiction and you're in recovery and you want to be made safe and not be prescribed things that will interfere with my addiction. And you say that and you're clear that over 50% of the time you will receive something from the doctor that could jeopardize your recovery. The doctor it's not that they are being mean, I do not think. I think they just don't know. Again, restate it here. I told the doctor I was in recovery, so I have nothing to worry about. And then the thought, my doctor is probably a drug addict, which, 25% chance you're going to be right, based on Dr. Christensen's discussion here. So the family member sitting there has very similar thoughts and fears. This most common is the doctors, they've seen it happen before. The doctor's about to give their loved one something that's going to put them over the edge, whether it's a pain reliever or a sedative or a stimulant or something, a muscle relaxer. Sometimes they just, there's such a bad relationship between the person in recovery and their caregiver. I hope the doctor gives them something so they can relapse. I liked him better when he was using. These things are common thoughts. There's the person in recovery who maybe needs a few more Al-Anon meetings or maybe has just the right amount and says they should suffer in pain. That's what they should do. There's really nothing the doctor can do. Those are common thoughts. And again, the family member believes perhaps the doctor is a drug addict because they've run into those before. So that creates a really difficult environment when you're trying to ease someone's pain, if you're the treating physician. And if you're the caregiver, adding fuel to that fire creates anxiety for the person with addiction. And I'll tell you, the anxiety tends to make the pain experience worse, makes the misery worse, and probably has a destabilizing effect on their recovery. So whether you're in recovery or you're a loved one of someone in recovery, remaining calm, and you'll learn a few tricks here, will be very, very effective. So one of the thoughts that's really hard to break, especially people who are opiate addicts, are that the only good medicines for reducing pain and suffering are opiates. True or false? False. Well, you were listening to Carl's talk, so you've kind of learned that. But it's really a hard thought to displace when someone's actually in pain. They are someone who has used opiates or other drugs, especially opiates, and you're trying to explain to them that opiates are not a good idea. Now, for someone who's really trying to hold on their recovery, it's not so hard to have the conversation, but still that thought is very deeply rooted because that's the way our society has managed pain, by just throwing opiates at everything that hurts and seeing what happens. So those who said false are true. It's actually, it's false. It really depends on the situation. Now, there are certain situations where opiates are okay, and we'll talk about that briefly. But the effect of opiates differ from patient to patient. In some patients, they are not a risk. In some patients, they are definitely a risk. And there's a gray cloud in between of who's who. In fact, as Dr. Christensen presented, there are many people who don't know or don't think or never had addictive behavior, but get exposed to opiates and things go really poorly. Again, the effect of opiates in a lot of ways has paradoxical effects, which means the opposite effect than you intend, or the opposite effect that you expect. One paradoxical effect is that the longer someone is on opioids, their system changes, whether they're addicted or not, and their pain becomes worse. It messes up the regulatory system within the body for sensing pain, and pain is sensed at a higher point. That's called opiate-induced hyperalgesia. Another paradoxical effect, just so you know, is most people who don't have addiction, who are given an opiate, get sleepy, a little nauseated, and really don't want to use the rest of their prescription. And if that fits people in the room, you might be in the wrong lecture. But for people who have opiate addiction and they're given an opiate, they have a boost of energy, they feel wonderful, and they clean the garage, even if it doesn't need to be cleaned. That is a paradoxical effect. Listening for that in a patient's story can be very helpful in identifying whether or not there's going to be a problem. And again, when you talk about the pain part, that experience is a combination of physical pain. It is sort of this being miserable, which is not always the same as having pain. And then there's craving, which can be very miserable. These things all need to be weighed. There are many patients that I know who have had opiate dependency, had a procedure where the doctor prescribed opiate medications like Norco or Percocet. And when they were kind of through the whole issue that they went through, which was usually not good, they would say, almost universally, the craving was far more disturbing than any physical pain that I had during that operation. The craving that occurred afterwards, because they really wanted to hold on to their recovery, but they were chemically challenged because they had been exposed to opiates. So true or false, if a patient ever had a substance use disorder, especially to opiates, they should never get any treatment for pain, any pain treatments at all. False. Very important. So the person who thinks they shouldn't get treated, who has those thoughts, really needs to rethink this, because the opposite is true. People who have addiction, it is extremely important in recovery and active addiction that their pain and their medical conditions are treated very thoroughly, because without that treatment, again, the recovery is destabilized and they will often make decisions that are problematic. So people with addiction definitely deserve treatments. The treatments may be better, actually, because we just heard throwing opiates are not really good at all types of pain. Therefore, getting non-pharmacologic approaches, non-narcotic approaches, other interventions is probably where treatment is going for everyone in regards to chronic painful conditions or even acute painful conditions. And again, there's that balance of pain, misery, and craving that has to be taken into account. So true or false, if a patient ever had a substance use disorder, especially to opiates, they should avoid self-administered pain medications. True. Why? Okay. So when you take a step back and look at addiction and substance use disorder, one of the problems, one of the targets of addiction is a profound decision-making disturbance around taking all mood-altering substances. It is incredibly challenging for someone who had opiate addiction, opiate dependency, to be in charge of managing their pain medication, especially if it has one of those elusive instructions like as needed. It is hard to figure that out. When you have addiction and you feel great when you have a pill, and it's a super normal release of dopamine where someone feels just wonderful, it is hard to not need that if you have had addiction or if you're just a human being who has that experience. It is really challenging. So self-administered medications are problematic, especially opiates, Norco, oxycodone, Percocet, all those fun things, but also benzodiazepines. Someone who has, again, we talk about drug of choice, but when we really understand the nature of addiction, it is not about the drug. It is about what happens in the brain. So somebody who is technically an opiate addict is likely going to have lots of problems with benzodiazepines, with soma, which is a muscle relaxer type of benzodiazepine, and any of those substances can cause an addiction to develop. Eventually, people will, for reasons that are hard to explain, gravitate toward that drug that they mostly use that maybe is an imprinting thing. They will start with Xanax, they'll end up on heroin. It is a problem. It is not a safe alternative. So true or false, pain, whether acute or chronic, mild or severe, should be addressed in patients with addiction because failing to do so can jeopardize their recovery. True, that's an easy one, and we just kind of talked about that. Again, not just untreated pain, but any medical issue that is untreated is probably a risk to someone's recovery. So if you have hypertension, if you have diabetes, if you have COPD, if you have asthma, and you're not getting these things treated, what I see happening is patients develop worsening physical health, a certain level of misery, and that ends up triggering the need to go back and use for reasons that may make perfect sense to people with recovery. Again, though, on the other hand, when people are using lots of sedating drugs and they enter recovery, it's very important for us as addiction specialists to keep an eye out for unmasked problems. Like somebody could be taking so much heroin and Xanax that they're completely suppressing their suicidality and their severe depression. And when they're off all that stuff, we need to make sure they get treatment. So what can you do? What is there to do when you're in this situation? Well, I think the most important thing is probably to find someone who knows what they're doing. At this point, there are a few options, but most likely it's finding someone who has some experience or certification in addiction medicine. That's the field that I have, Dr. Christensen has, we are certified to do, which we are trained specifically to handle these types of situations and to give appropriate guidance. This can be helpful, very, very helpful to the patient who's in that situation, but even having us as in your back pocket, someone to call, can be very helpful to the doctor who's trying to treat you. Because often the exposure for a surgery or something like that is coming from a surgeon. It's not something we're going to treat, but we can work with the surgeon to help guide them how to take better care of you or your loved one who has addiction. We can also help come up with treatment plans that may recommend changing certain drugs that may be more or less. We like ones that are less likely to destabilize recovery. What you can do in general is be extremely cautious about any drug that you want to take, any substance that alters your mood, treats pain, helps you sleep, or wakes you up. Any drug that changes any of those things. I mean, I don't know about Monster and all that stuff out there, but there are potential problems with anything that changes your level of alertness. And the same is true about herbal remedies. Not every herbal remedy is safe. Some of these can be very problematic and can destabilize addiction. And if there's ever an option to avoid a procedure where you're going to be exposed to opiates or sedatives in your early recovery, which is anywhere from 1 year to 10 years, whatever you can avoid it, you push it out, because the longer you have developed, hopefully the longer you're in recovery, the more stable your recovery foundation is, the more easily you will be able to get through that difficulty. But often it's with the help of various people in your support system, including someone who knows something about addiction medicine. So what I recommend to people who know they're about to be involved in a painful condition or a painful surgery is to create a plan that leverages your recovery supports. It gets people involved. You let people know who are your friends in recovery. If you're in the Al-Anon program, you let your Al-Anon friends know your husband or spouse is about to go through a treatment. You might need some help. But you get people involved to help you with your accountability and to know that you're going to be safe. Therapists should be involved in this plan if you're involved in therapy, and family and friends. And everybody should know what's going on. These problems are much, much worse when kept in secret. So the more you share with the appropriate group, the better. And I think just understanding that exposure can destabilize your recovery means that when you are about to enter this sort of potential procedure situation, that you, if you're in recovery, increase your meeting attendance. If you can, if it's something where you need to take time off work, get to a meeting once or twice a day. These things I have seen help people get through these situations and not have to relapse. So with that, I will turn this back to Dr. Christensen.
Dr. Weiner brought this up, and we'll talk about this in a little bit more detail. Why come off pain medications? Okay, so one major reason is safety. Pain medications are a major cause of death under age 50 and probably over age 50. And it doesn't go away. Even if you've been on a medication for some time, you still risk having accidents, having falls, oversedation, and respirations can cease. So you may develop addiction, and we think that, addiction is not necessarily caused by the medications, but can trigger it in somebody who has the genetic underlying or someone who's been through sexual or emotional or physical trauma. And everybody who takes a pain medication becomes tolerant. And one way to treat that is to keep on switching the pain medication. That's called rotation, but you still wind up back where you started. Your body is used to it, it's not working like it used to. And then this is the biggie. This is what people talk a lot about. This is opioid-induced hyperalgesia, which means in English, the pain medications are making your pain worse. And that sounds like nonsense, but it's been shown to actually happen. This is something called the cold pressor test, which is putting your arm in a bucket of ice water. It's extremely painful. Somebody who is not on pain medication can usually last about 90 seconds. And this was a study done by Dr. Peggy Compton out in California, and don't worry about the numbers here, but what she showed was that people who were not on high-dose pain medications could last about a minute and a half. People who were on high-dose pain medications, who should be protected, right, lasted half as long. They did worse, okay? And that's hyperalgesia. And the only way to treat that is to get off the medication that you're on. So here is the control group, and here are the ones on pain medications. It's very dramatic. And people who have hyperalgesia will tell you everything hurts. You just raised my dose last week and already it's not working. And I can't seem to get anything done anymore, and I need more pain medications. They're not complaining of addiction, they're complaining of hyperalgesia. And again, ignore the numbers here, but this was a study where they took about 60 patients who are on high-dose pain meds, detoxed them off, and here's what happened to their pain scores. When they were on the pain medications, their average pain score was 7. Off pain medications, their average pain score was 3. That is so dramatic that you would never find any drug manufacturer that would ever claim that a medication could do that. The way they did that was by taking them off the medications. So how do you get off pain medications? It's never easy. And I do this for a living, and it can be a long, drawn-out, kind of miserable process. But you can taper somebody. You take them down about 10% per week, so it takes about 3 months. But what you have to tell them is during that taper, you're going to feel worse. And your pain's going to get worse. You're going to get miserable. And it's not going to get better till a month or two after you get off the pain medications. And that usually goes over like a lead balloon. Or you can just stop cold. And there are actually a couple of specialized centers in the U.S., one's in Cleveland, one's in California, one's in Las Vegas, where you throw away your pain medications. You spend about 2 weeks in a bathtub, and they have counselors for you and non-narcotic medications, but it's extremely uncomfortable because your pain gets worse, your withdrawal goes through the roof. Or you can use buprenorphine, which is Suboxone, and that is mostly approved for addiction, but it's also been used for chronic pain. And actually, Dr. Malinoff, who's an attending here, and Dr. Weiner have both been involved in studies showing that buprenorphine, Suboxone, seems to treat opioid-induced hyperalgesia. You can also use, this is very strange, naltrexone we talked about was the opioid blocker. If somebody who is in pain takes a regular dose of naltrexone, they're miserable. It blocks everything. But if you take a tiny amount, and we actually talk about taking 1 pill, dissolving it in a pint of water, and taking little teaspoons, somehow that seems to help your pain, and nobody really knows why, but that's also used. And this is, well, let's skip the study. This is Dr. Malinoff saw a 50% reduction in pain scores from more than 80% of his patients, and then Dr. Malinoff and Dr. Weiner, along with Dr. Berwin at U of M, saw the success rate about 2 out of 3 in getting patients off their pain meds. Okay, but a lot of people do well on their pain medications. That's something we're not denying, okay? And this diagram just shows how patients are caught in between the 8 ball and the doctors are at the end and they're going to go in the pocket. There's a lot of pressure on here to get patients off pain meds when sometimes it may not be the best thing to do. Some patients do better. Some patients taper off and it goes horribly. I've had patients who have done everything they could. They come off the pain medications and they come back a month later and they say, my life is shot, I'm in agony, I can't do this. Suboxone doesn't work for everybody. And one thing we haven't considered here is ethics, okay? One ethic we have talked about is do the right thing for safety, but also remember that a patient is partly responsible for their own decision. And I have patients who sit down, they look at the numbers, they realize the risk, and they want to stay on their pain medications. There's no denying that a lot of people should be allowed to stay on them. Okay, now, next thing. This is brand new. You probably heard about this in the past few days. These bills just got passed. These bills caused a war, okay? And the war was the Michigan State Medical Society against everybody else. There was a lot of pushback on having any laws that told prescribers, told doctors what to do. So let me just show you what they are. The first law is minors. You have to have a whole setup for informed consent, including the minor and including the guardian. After seeing that stuff about 1 out of 20 people will take a pain medication and never get off, you realize that's not a bad idea. But this is a brand new law. Next law, you got to give informed consent to adults too. You have to talk to them about the risk of addiction, the risk of death, the risk of dependence, meaning even if you don't turn into a heroin addict, you can't get off the medication, and how to get rid of the medication, and sharing it with somebody, which a lot of patients do, is a felony, okay? People have gone to prison for that. And I know doctors who have been arrested when the prescription they wrote wound up in someone else's hands. The doctors wound up getting in trouble also. If you're pregnant, you need to understand that there are risks to a baby who's exposed to pain medications, and the baby may go through withdrawal, and the baby may have permanent changes that we don't understand. Next law, you got to run a MAPS report, and this sounds kind of obvious, right? It was a huge, huge fight. Doctors saying, you can't tell me what to do, okay? Well, someone has. So if you're going to prescribe 3 days or less of pain medications, you don't have to run a MAPS. But if you're going to write for anything more than 3 days, you do. And I think this is a law that really is very beneficial because you may find that your patient is going to 10 other providers and getting Valium, getting Xanax, Soma, and everything else we've talked about. Next law, 7 days for acute pain. This is the one that I don't like because you can't control what day you're going to get injured. Okay, so let's say you get hurt Saturday night and you go to the hospital and they give you a 7-day prescription and it's not enough. And in many cases it won't be. Guess when you're going to run out? Saturday night. Where are you going to go on Saturday night? You are out of luck. I'll leave the expletive out in front. But if you have a 7-day limit to medications, unless your doctor has electronic prescribing, which most doctors do not, there's no way a doctor can call in Norco. It's a Schedule II medication. So you have to go back to the ER and spend the entire night in the ER getting another prescription. This, I think, is a flawed law, but it will probably be adjusted in the future. No pill mills. You have to have what we call a bona fide physician-patient relationship, meaning that if you come to see me for pain meds, I've looked at your records, I reviewed your history, and I've checked you out for the obvious signs of addiction before I give you a prescription. Again, I don't think there's much you can say bad about this. Okay. Now, why don't we do this quickly, and then we can take questions, and then anybody who wants to get a certificate signed, you will be able to take it to a pharmacy, and it will show that you have been trained in what Narcan is about. Okay, so we'll do this fairly quick. So there's 2 drugs we've been talking about all night. One is naltrexone. That's the Vivitrol shot that blocks you for a whole month. The other is naloxone, which is known as Narcan. That's what you give somebody when they've overdosed, and it lasts only a few minutes. This lasts days to a month. So this is quick acting. This one is long acting. And Narcan will reverse an opioid overdose. It will not reverse an it will not reverse a sedative overdose, an amphetamine overdose, or alcohol. So if your loved one has mixed opiates and sedatives together, which is very, very common, it's not going to treat those, but it may bring them up high enough so they can keep breathing until they can get to the hospital. There are different formulations involved, and these are the ones that have been around for a long time. Oops, not that one. These have been around for a while, and these are 0.4 milligrams. And I've been using 0.4 milligrams since 1978 when I was a 4th-year medical student. And over the past 2 or 3 years, because of the opioid epidemic and because of fentanyl specifically, they came out with a 4 milligram dose, 10 times as much. And when you buy a pack of these, this is what you're going to get if you take that slip to the pharmacy. It has 2 sprays in it. Okay, so that's 8 milligrams of Narcan. That's about 40 times more than we used to give patients, all because of fentanyl. And this is our therapy dog, Olive. So who overdoses? Somebody who is using regularly and takes the same amount of medication every day is not safe, but they are at a relatively low risk. The people who overdose are the people who have stopped. People who go into detox, treatment, jail, okay? They go onto medications, and then they relapse, and they are now sensitive. People who stop their medication-assisted therapy, people who are kicked out of a methadone clinic, stop Suboxone or Zubsolv, stop Vivitrol. Once you've stopped, your body is now sensitive. And here's the biggie, people who mix opiates with alcohol, benzos, or muscle relaxants, and that accounts for about 1/3 of deaths. And here is the bull in the china shop, fentanyl. Fentanyl is present in Detroit, where we have our methadone clinic. 50% of the urine samples that have heroin in them have fentanyl in them. It is a 50-50 crapshoot that if you buy heroin in Detroit, you're going to get fentanyl. And unfortunately, those of us at the clinic used to think that we needed to warn them right away and tell them, you know, you need to stop. And we found that once you told them that they were getting fentanyl, their eyes would light up, okay? It's kind of like you rented a Chevy and you got a Corvette, okay? And it backfired. So we try and keep them in treatment as long as we can, and we tend to raise their dose because we know that we have to cover this very dangerous drug. And all this says, don't worry about the numbers, all this says is that in the past, prescription pills were the killer, and now in the last 2 years, heroin has again become the killer. So it's become reversed. So we used to say that there were a certain number of heroin deaths every year, prescription pills were going up, and now heroin is chasing the prescription pills and could even someday overtake it. And it's not because of heroin. It's the same heroin. It's because of what's mixed with the heroin, which is either fentanyl or you've heard of carfentanil, which is used for operating on a 20,000-pound elephant when you don't want it to wake up during the surgery. And here is a patient that came to our methadone clinic who wanted to get on methadone. Here is fentanyl, norfentanyl, and here's the hydrocodone, same kind of presentation. This patient is getting fentanyl, and she's pregnant, okay? So she's at very high risk of complications. And this baby's at very high risk of having withdrawal when it's born. So how do you do a Narcan rescue, okay? And if you go on YouTube and you type in CC Ph.D, that's my YouTube channel, and I've got the Narcan videos on there, or you can just put in Narcan video on YouTube and about 100 of them will come up. But basically, you want to make sure someone's not breathing, okay? So sometimes you're sleeping it off, okay? So if you come in and someone's on the floor and they're not moving, you want to jostle them. You want to make sure that, you know, they're arousable, and if they don't seem to be aroused, you can do something that is unpleasant. You can rub your knuckles on their breastbone. You can mash your knuckle under their nose, which is very painful. Twist their ears, something that would normally be very obnoxious. If they don't respond, you've probably got a problem. Here is the second thing you should always do. Don't resuscitate them first. Call 911 first. Why? Because if you forget this step, you're going to lose your loved one. Because you will give them the Narcan, you're doing rescue breaths, you're asking yourself, where is 911? And then you realize, I never called them, okay? And when I first made a video for this a couple of years ago, I went through the entire thing. It took us like a day, and I realized I left this step out, and I had to go back and do the whole video again. It's the one you naturally forget to do. Now, how many people here are trained in CPR? Sorry. What you're supposed to do when someone overdoses from opioids is rescue breathing, not CPR. CPR moves your blood, but it doesn't necessarily bring oxygen back in your system. So you are supposed to do rescue breathing, and the way you do that is you stretch them out on the floor, you tilt their head back, you pinch their nose, and blow in their mouth. And what you're looking for is you're looking for their chest to move. That means their lungs are being inflated. If their stomach moves, you're blowing air into their stomach. If you see their stomach move, tilt the head back a little farther and do it again. If you're lucky enough, you'll have a rescue mask so you don't have to breathe right in their mouth, because there is a danger of doing this. If they have been using carfentanil, it may kill you, and it's happened. So it is not a risk-free procedure for you anymore compared to them. And then once you've done a couple of rescue breaths and you want to do 2 breaths, and then you can go ahead and give the Narcan. The Narcan nasal spray, as you saw, is very easy. You just take it out of the package, put your thumb, and don't test it, Because if you go like this, you'll spray it all over the room, and it's gone, okay? You tilt the head back, put the spray in the nostril, and just push. That's all you got to do. And there are 2 kits, or there are 2 sprays in the kit. You wait about 3 minutes in between, and during that 3 minutes in between, you keep doing rescue breathing. Now, again, someone is overdosed if they're gurgling, snoring, their body is limp, not limb. Their fingernails are blue, you can't wake. And remember, just because they have a pulse doesn't mean they haven't overdosed. Your heart is the last thing to stop. So you want to, if a pulse is going on, that's okay, but you may still need to do rescue breaths. And here is the unpleasant things to do. And call 911, and you can leave the phone on speaker and lay it next to you, and they'll talk you through it, unless you're in Detroit, in which case I'll probably hang up on you. So we've talked about this. The abdomen should not move. The chest should move. 2 breaths, and then after that, you give a breath every 5 seconds. And here is a breathing mask. If you have a loved one who you think may overdose and you may need to save them, you should order this on Amazon. It's a rescue breathing mask. It's $7. You don't need a license to get it. And we bought a bunch of these, and considering that carfentanil may be involved nowadays, it's much safer, and it protects you from getting an overdose as well. And I didn't put these videos on, but you can find them online very, very easily. This is an old injector that has been revived, resuscitated. It's called Esvio. It talks to you. So you pull the cap off. It says, you know, stick it in the thigh, and it counts down from 1 to 5, and then pull it out. And then that helps tell you how to use it. And for the money it costs, it should do more. But it is the most expensive one because it's computerized, and now they come out, I think, in a 2 milligram and a 4 milligram dose. And here is the most common one. This is called the Adapt. If you go to a doc's office, on their computer, my computer, if you give a patient Narcan, it's a 4 milligram Narcan nasal spray, and that's the Adapt. It's $75 cash for 2 sprays. And if insurance covers it, it may be free. And then once you save somebody, you've got a bigger problem. You need to talk them into getting treatment, which is what we'll talk about in February. Okay. That's it. So, Dr. Weiner, why don't you come up here and we can answer any questions? The question is, how unpleasant is it to come off Suboxone or buprenorphine? And the answer is very.
For the doctor or the patient?
Primarily the patient.
Both of us, actually.
Someone will be in withdrawal for 2 to 4 weeks, and I often encourage people to come off work. We have medications to help that relieve some of the withdrawal, but it is a difficult medication to come off. Because at a certain point, when you stop, and we call that the jumping off point, that's when your brain empties out and your brain is very handle. For your help.
One of the things to improve outcome, I discussed briefly, when people are planning that very last step off, they can be doing very well down to 1 or 2 milligrams a day. When it gets to that last week, that's when it would make a lot of sense if you're in recovery to let all the people in recovery know what you're doing, know that you're going to be miserable, plan to go to 2 to 3 meetings a day, and let everyone just keep it out in the open. The outcome is better. I wouldn't say it's guaranteed. It's still a very difficult outcome. In general, without any intervention, abruptly stopping Suboxone leads to a relapse nearly 100% of the time. You need to have other things involved.
So the question is, would a t-shirt be better than nothing at all if you don't have a mask? And I think the answer would be yes. Yeah. Question is, do you need to do the rescue breathing? If you give the Narcan and it resuscitates them all on their own, one thing I didn't put in there was they talk about being in a safety position, which means on your side, so that if you vomit, that it comes out instead of going back in your lungs. If the Narcan by itself works, okay. One of my friends who trains first responders and law enforcement up in Saginaw assumes that no one is going to touch the patient, so he doesn't even bother teaching rescue breathing. He figures no one's going to use it.
I have a whole talk on that. But it's a challenge. I think the first part is just to say that, let them know you're in recovery and that you want help. You can add, I really would like to get involved with someone who knows how to treat patients in recovery. Do you feel you know enough, or do you know someone you can refer me to for an evaluation? Now, in the very beginning, when I gave this talk, I would think that most doctors would be annoyed at somebody kind of bringing up, can you refer me to somebody else or get somebody else's opinion? Because, doctors are all egotistical and they think they know everything. But nowadays, with what's going on, I think most doctors are just very happy to refer patients who have addiction to, at least in this environment, to an addiction medicine specialist to get some input. So you may want to just start with, can we get an addiction medicine specialist involved and see where it goes from there.
So the first question was, is the nasal Narcan only for the nasal cavity? There's a direct connection between the veins in your nose and your brain, so it's much more effective when taken that way. And the other comment was that only a tiny, tiny fraction of folks who get in trouble make it to rehab, and it is a depressingly small number. I can't give you the exact number because it varies on the situation, but most people do not make it to treatment, even if they're revived. And the repeat overdose rate is 15% or more within that year. They'll overdose again. I've had patients who overdose 3 times in the same day. So the main exemption to the informed consent is an emergency or incompetency, or not being able to to give consent. But otherwise, if someone is awake, alert, and is an adult, you're supposed to get it. And they are going to be publishing the forms that we have to use. The forms are not out yet. The paper you're referring to was written by someone named Porter back in 1980. It was a hospital chart review that was completely unverified, and those authors are chagrined about it to this day. They're vilified, actually. And it was just not a good study, and it was held up because it came from the New England Journal. Speaking about Vietnam veterans, I have a friend who was one of those Vietnam veterans who was treated and was supposed to be in spontaneous remission and brought back to the U.S. He continued to be an active heroin addict for about another 30 years. Again, these studies are terribly, terribly flawed. And it is true that a lot of people who abuse drugs will spontaneously go through remission. But there's a significant number of people, and again, depending upon the situation, it's anywhere from 5 to 25% who will develop full-blown addiction. And that, my attitude towards that is, I'm also an OBGYN, and if I said that ovarian cancer was not a problem because only 1% of women died from it, I'd be lynched. And it's really a similar situation. It's not a majority of patients who will become addicted, but it is a significant number.
The question was, are we optimistic that the laws or the regulations that have just come down with opioid prescribing will make a difference?
With MAPS too.
Yeah.
Including
so it depends what difference you're looking for. For a number of people who take care of doctors in large systems and they look at the number of opiates prescribed, I bet you this will make a significant impact and reduce the amount of opiates prescribed. From someone who treats the person who's addicted, I do not think it's going to make a huge change. We would hope that with less tablets out there, less people will be exposed in vulnerable periods and less likely to develop addiction. But, on the other hand, people who have been receiving opiates who suddenly get cut off do what? They use heroin, right. And so I think it's not a coincidence that when Norco went to Control 2 in 2014, we started seeing an increase in heroin overdoses. It could be related to the reduction in supply. I think there were a lot of other factors involved as well. So it depends on what you're looking for. I think there will be some positive outcome, but I don't think it will eliminate addiction, for instance.
So the question is, what do you do if you have hyperalgesia and you have those choices? Okay, you can taper, you can go cold turkey, you can go on buprenorphine. If you're not willing to do that, a lot of people simply feel that it's just too difficult to do any of those and want to stay on their medication, even if you explain that their pain is probably being made worse, because the withdrawal is the worst part of all for them. Well, with non-narcotic medications or not with medications at all the stuff we talked about with the first guideline.
So one of the things that when we look at our society compared to others, there's chronic pain in every human society in the world. Our society has developed an expectation that pain is not something to be part of our life. And we're taught that, and we're not taught in America the skills to kind of handle day-to-day pain and just kind of survive and realize we don't need to gobble a bunch of medications to handle it. Although, that being said, there are things that I think help. Some non-pharmacologic techniques involving yoga, meditation, mindfulness, and if someone has had adverse life experience or early life trauma or abuse, I have seen a significant improvement in their outcome with something called pain psychology counseling, which is available through pain psychologists.
Okay, it's 9 o'clock, so we'll stick around for any further questions, but thanks for attending. Yeah.